We're now going into a session entitled Who Listens to the Community? And the first person we have talking to us is Dr. Brian Smedley. He's a co-founder and executive director of the National Collaborative for Health Equity. It's a project that connects research, policy analysis, and communications with activism to advance health. Dr. Smedley, until 2014, was vice president and director of the Joint Center for Political and Economic Studies Equity. This is a research and policy organization focused on, again, on addressing the needs of communities of color. He worked as a senior program officer at the Institute of Medicine, helping to produce a number of reports that addressed health disparities, diversity in the health professions, and minority health research policy. He's received a number of prestigious awards for his work in this area from the American Public Health Association, the Congressional Black Caucus, and many other places. Please welcome Dr. Smedley.
Thank you very much, Cindy. It's a real pleasure to be here. I've been delighted to participate in this summit in the past and always find it very enlightening. My presentation connects very well with what Susan was just talking about in terms of talking about the neighborhoods in which we see higher risk for women being unable or unwilling to breastfeed. And we do a lot of work focused on spaces and places, neighborhoods. What are the influences of neighborhoods and characteristics of communities that are facilitative of good health and good health behaviors like breastfeeding? We know that context is very important. Context matters because many of our neighborhood opportunity structures, which I'll say more about, vary considerably, particularly along the lines of race and ethnicity. So we know that in too many communities of color and low-income communities, we see a heavy concentration of health risks, including characteristics, attributes of neighborhoods which constrain healthy behaviors. So the space is occupied by people of color, neighborhoods, workplaces, schools. This heavy concentration of health risks, in fact, we think is at the root of many of the inequities that we see. So what factors, what neighborhood factors influence breastfeeding, for example, in a low-income rural community? Well, this is from a study published in 2011, but I'd argue that many of the same issues apply in other kinds of settings, urban, suburban, frontier communities. We know that individual factors, of course, play a role. Individual attitudes, beliefs, personal history, knowledge, all of this shapes health behavior and decisions to breastfeed or not. Interpersonal factors, however, often relatively understudied, underappreciated, particularly when we think about community context. We know that social networks and social support systems, families, friends, work groups, all of these influence knowledge, attitudes, behaviors around health behaviors such as breastfeeding. Organizational factors. We know that the context in which we go to school, the context in which we work, the institutions and organizations that we interact with on a daily basis shape our attitudes and behaviors. Hospitals and healthcare systems, of course, are an important frontline interface for young mothers who are making decisions about breastfeeding. There are community factors. Often, again, underappreciated is the role of social norms. We do what others in our communities tend to do. Those social norms are very powerful in shaping our attitudes, our behavior, our knowledge around health behaviors. And so we need to consider what are the consequences of high levels of poverty concentration, economic and political marginalization. Those kinds of social, political, and economic forces, I'd argue, also shape attitudes around specific health behaviors. And then, of course, there are policy factors. Our local, state, and federal governments can powerfully shape attitudes and behaviors around breastfeeding and many other health-related behaviors. We know that more attention has to be paid to these community-level factors that shape breastfeeding knowledge and attitudes, factors like overcrowded housing. Do young mothers have an opportunity for privacy for breastfeeding? What about the quality of the housing stock? Does the housing present risks such as lead exposure that may in turn shape women's decisions around breastfeeding? Workplace policies, of course. We all, I think, understand the importance of workplaces that are facilitative of breastfeeding, having spaces, for example, for women to lactate or to, in fact, have their babies with them. The retail food environment also becomes very important. In our work, we focus quite a bit on what's bought and sold in the community. What kinds of nutritional choices are there? We know that in low-income communities and communities of color that are highly segregated, too many of these communities are characterized as food deserts, lacking affordable, nutritious produce. But in contrast, many of these communities are overrun with vendors selling unhealthy, not only food products, but disproportionate alcohol and tobacco advertising, which again shapes decisions around breastfeeding. We know that the presence of pollution and environmental degradation also plays an important role. Again, too many communities of color that are highly segregated face very high levels of exposure to industrial pollution. Thanks to a study by the United Church of Christ in 2004, we know that 56% of people who live in neighborhoods with commercial hazardous waste facilities are people of color. And at that time, of course, there was people of color were only about a third of the U.S. population. Also, disproportionate alcohol, tobacco, advertising, and sales, I mentioned that earlier. These are among the many kinds of neighborhood factors that shape those attitudes and behavior around breastfeeding and many other health-related behaviors. Now, in our work, we've tended to emphasize the role of residential segregation. I'm going to very quickly go just point out that in many U.S. cities, we're as segregated as apartheid-era South Africa was. I'm not going to go into depth on this slide, but this slide basically shows a measure called the dissimilarity index, which is the percentage of two population groups that would need to move to create complete integration within a defined geographic area. In South Africa in 1991, prior to the dismantling of apartheid, about 90% of white and black South Africans would need to move to create complete integration in that country. And we compare here several major U.S. cities: Detroit, Milwaukee, New York, Chicago. All of these cities had dissimilarity indices of 80 or higher, meaning that 4 out of every 5 black and white residents of those cities would need to move to create complete integration. If we were to map the dissimilarity indices comparing Latinos and whites, we would see similar numbers that are very striking, not quite as high. Latinos tend not to be as isolated as African Americans, but nonetheless unacceptably high levels of residential segregation. Let me just illustrate this with one last slide, and then I'll conclude. And this is looking at the percent neighborhood poverty concentration for Americans of different racial and ethnic backgrounds. First, let's look at white Americans, which is the bar on the far left. Here we're looking at the nation's largest metro areas. This does not include rural areas, but in the nation's largest metro areas, about 90% of white Americans live in neighborhoods with low to moderate levels of poverty concentration. That's the green. Those are neighborhoods with between 0 and 20% poverty concentration. Those are the healthy spaces where you want to raise your children, and in general are more facilitative of healthy behaviors. The same is not true for African Americans, Asian Americans, American Indians, and Latinos. They are much more likely to be found in neighborhoods with medium and high levels of poverty concentration. So for African Americans, for example, only about 55% of African Americans in metro areas in the U.S. are in neighborhoods with low levels of poverty concentration. The rest are in medium and high neighborhoods of poverty concentration. And similarly, other communities of color are also more likely to find themselves in neighborhoods with high levels of poverty concentration. Now you might ask, isn't this to be expected given differences in wealth, income, and education levels across different racial and ethnic groups? Of course, many people of color are more concentrated in lower socioeconomic tiers, the result of inequitable economic and educational opportunities. But even if we control for these differences just by looking at families living below the poverty line, you find, again, a very striking finding. The set of bars on the far left are the percentage of poor Latino, poor black, and poor white residents in neighborhoods with low levels of poverty concentration. In other words, these are poor individuals, but these are individuals who are less likely to live nearby or next to people who are similarly poor. About 70% of poor white Americans in our metro areas live in neighborhoods with low to moderate levels of poverty concentration, between 0 and 20%. In contrast, only about a third of similarly poor African Americans and about 40% of similarly poor Latinos live in those neighborhoods with low levels of poverty concentration. But those poor black and Latino families are much more likely to be found in medium and high neighborhoods of poverty concentration, much less so for poor white Americans in our metro areas. The point here is that this is one of many reasons why we should never conflate race and socioeconomic status. They're not the same. We don't want any child to grow up in poverty. It's bad for their health and human development. But on average, if you're going to be poor, you better hope that you're white, because you're much more likely to live in neighborhoods with low levels of poverty concentration. Okay, thank you. I don't want to take up too much time from our other speakers, so hope that was okay. Now I'm assuming we'll take questions later. Okay.
That was great.